Thank you so much for tuning in today to hear about discoveries in neuropsychiatry. From an Alzheimer's cure to accelerated TMS and neurosurgery for major depressive disorder, what works and what doesn't, and how these interventions fit in with consult-liaison psychiatry. I have no relevant disclosures. It is my distinct pleasure to introduce my co-speakers today. Dr. Helen Kales is the chair of the Department of Psychiatry at UC Davis and a renowned researcher in geriatric psychiatry. Dr. James Bourgeois is known to many of you from his work at ACLP. He is the UC Davis Vice Chair for Hospital-Based Services and the 2021 winner of the Eleanor and Thomas P. Hackett Award, the greatest honor bestowed upon a CL psychiatrist. And finally, I'm Dr. Debra Kahn, Director of the Advanced Psychiatric Therapeutics Clinic at UC Davis. I'm also the CL Fellowship Director and a transplant psychiatrist. So just a little bit about UC Davis. We are in California. We are on the West Coast. Within California, we are in the central and north area. We are close to both excellent skiing and the beach, and it's a wonderful place to come visit. Sacramento was initially inhabited by indigenous people. The Maydew tribe was the primary inhabitant. Later on in the 1800s, first Spanish settlers and then Swiss, German, and English settlers came to the Sacramento area. We were a major site of where people stopped on their way to find gold in the gold rush in the 1850s. Currently, we have a population that is quite diverse. You can see our demographics: 30% white, 30% Hispanic, 20% Asian, 11% Black. We have 500,000 people in the city center, and we have 2.5 million people in the greater area. We are known as the farm to fork capital because we grow much of our food and we have wonderful restaurants.
Hello, I'm Helen Kales. I am the Joe P. Tupin Professor and Chair of Psychiatry at University of California, Davis. And my portion of the symposium is on new treatments for Alzheimer's disease, blazing trails or road to nowhere. This is my disclosure, which notes that I do not have anything to disclose. The topics I'm going to cover today include a broad overview of Alzheimer's disease, the amyloid hypothesis, the history of treatments that are based upon the amyloid hypothesis, anti-amyloid antibody treatments, and then lastly, we'll touch upon whether there are other paradigms that we may be looking to shift to. And that includes paradigms of modifiable risk factors and prevention, and the preliminary ideas from the field of neuromodulation. So we'll start with an overview of Alzheimer's disease. There are over 7 million people in the United States that are estimated to be impacted, and that number is expected to rise to 14 million with the aging of the population by 2060. It is currently the 6th leading cause of death in the United States, and Alzheimer's disease is characterized by memory loss, impaired cognitive capacity, and importantly for us as psychiatrists, abnormal behavior. And I would note that it is typically the behavior that brings people to us. Over 98% of people with dementia are estimated to have behavioral difficulties. And again, these are often the problems that bring them to treatment. In terms of Alzheimer's disease, 95% of cases are sporadic, whereas 5% are familial, which is to say genetic, and linked to specific mutations. This is a disease that also affects the entire family. And in the United States, over 12 million family members provide care for this illness with multiple difficult outcomes that include stress, depression, and because of all the risk of stress and depression and health consequences, the risk of dementia itself for caregivers. So let's talk about the amyloid hypothesis. This hypothesis has dominated research in Alzheimer's disease for more than 25 years. And it focuses on amyloid, which is a single small post-translationally generated peptide, amyloid beta, or shorthand A beta. A beta has 40 or more typically 42 amino acids, and it's produced by the cleavage by an enzyme of a much larger protein, which is called A beta precursor protein. It's thought that aggregates of A beta are present in the brains of patients with Alzheimer's disease in the form of what we call plaques. And it's proposed that the leading cause of Alzheimer's is the accumulation of these A beta plaques. So again, it's hypothesized that the accumulation of A beta occurs over a series of molecular events, and those trigger a lot of the problems that we see in dementia. It was way back in 1906 when senile plaques were first discovered, but it wasn't until 1984 that A beta was purified and found to be a key component of plaques in brains with Alzheimer's disease. In 1987, A beta was found to be produced by the cleavage of amyloid precursor proteins. And in 1990, the neurotoxicity of A beta aggregates was demonstrated. The amyloid cascade hypothesis was proposed in 1992. In 1995, the relationship between A beta and inflammation was identified. And in 1998, the A beta oligomer was identified as the key offender of neuronal damage. In 2001, the link between A beta and neurofibrillary tangles was demonstrated. So again, to sort of break this down schematically, we have the accumulation of A beta, which is resulting from the cleavage of a larger precursor protein. This accumulation then triggers a series of molecular events, including hyperphosphorylation of tau, activation of neuronal death, and eventually dementia. So as one author has put it, A beta is the killer, tau is the smoking gun, and neurons are the victims. So what is the evidence for the amyloid hypothesis? Here are some of the pros. In terms of pros, genetics play a large role. So we know that mutations of chromosome 21 appear to increase amyloid beta aggregation. And in people with Down syndrome who have an extra copy of chromosome 21, we see the early appearance of Alzheimer's pathology with almost 100% of people with Down syndrome affected by age 70. More recently, there has been a shift from the focus on insoluble plaques to that of toxicity of soluble oligomers and the thought that they disrupt synaptic function. There is also found to be interactions with apolipoprotein E. So we know that is a gene variant found on chromosome 19 that presents the strongest risk factor for late onset Alzheimer's disease. E4 appears to be associated with A beta plaques in a dose-dependent manner. Lastly, there's the analogy of cardiac amyloidosis, which is where amyloid accumulates in the heart, and pharmacotherapy has been found to reduce morbidity and mortality. However, have been proposed a number of cons of the amyloid hypothesis. That is that plaques are found in elderly persons with normal cognition. So over 60% of those over 85 are estimated to have pathological A beta burden, and yet they are cognitively intact. It is also known that familial disease is not a perfect phenocopy of sporadic Alzheimer's disease. And so while people with familial disease have this increased genetic risk and symptomatology that is characteristic for their type of disease, that is not a perfect transfer to sporadic Alzheimer's disease. It has also been found that plaque burden, so the degree to which you have a severity of plaques in your brain, correlates weakly with disease severity. There's also been a disappointing track record of drugs targeting amyloid beta. And this is an area, this last one, that is largely unexplored. But could amyloid beta have a protective function? That is, could it be something that is generated to provincially create a compensatory response in brains developing Alzheimer's disease? So let's turn to anti-amyloid treatments. There have been over 76 trials to date, and largely they have been ineffective, or they have presented a high rate of adverse effects. There are overall 5 categories of these types of treatments. The first is those that reduce A beta generation, and that would be treatments that inhibit the enzymes beta secretase or gamma secretase. The second is treatments that enhance A beta clearance. The third is treatments that would destabilize the aggregation of A beta. The fourth would be those that look to ameliorate the toxicity of A beta. And lastly, there are immunotherapy treatments. Currently, the FDA has approved 3 drugs that we'll be talking about individually. And these are largely operating by passive immunotherapy. That is, we infuse pre-made antibodies that bind and remove A beta particles. Now, notably, in this category, there have been 38 trials that have been discontinued due to ineffectiveness or toxicity of the treatments themselves. So let's talk about the 3 approved drugs by the FDA, which are monoclonal antibody treatments. The first is aducanumab, and this drug was approved by the FDA in 2021 based upon 1 positive trial showing clinical effect. Another trial had been negative. It was controversial at the time because it was felt that it lacked a broad base of evidence to support clinical efficacy. It was discontinued in 2024 by Biogen, which they stated was for business reasons. However, there were concerns that this was due to a lack of efficacy and side effects. The second drug approved, lecanemab, was approved because it was found in studies to significantly reduce brain amyloid and improve cognitive decline in the highest dose group. However, this was when it began to be noted that there were what were called amyloid-related imaging abnormalities, or ARIA, in patients receiving this drug. There are 2 types of ARIA. One is ARIA-E, which is edema in the brain, and the second is ARIA-H, which are microhemorrhages in the brain. ARIA-E was found to be present in 30% of people receiving the intervention drug, and ARIA-H in 10% of those receiving the intervention drug. It was also found in sub-analyses that ApoE4 was an important predictor of those who resulted in having ARIA. The third drug, which has been approved, and this is the most recent one, is donanemab. And this was approved based on the Trailblazer Alzheimer 2 trial, which was a trial of over 1,700 adults with early disease. And what was found there was a significant reduction in clearing of amyloid and a mean decline of approximately 3 points less for the treatment group on a 144-point scale of cognition and function. This was translated to a 23% slowing of disease over 18 months. The benefit on MMSE, which what puts this into clinical context for us over 18 months, was 0.48 points, so a pretty small benefit. This drug is a one-time monthly IV infusion over 30 minutes, and the dose is increased in over 4 infusions. In terms of ARIA, ARIA-E was found in 24% of the intervention subjects and ARIA-H in 20% of the intervention subjects. Other side effects include headaches and infusion reactions. So the monoclonal antibodies are somewhat controversial in our field, and I want to go over those controversies for you so you can be aware of these when considering referring patients for treatment. So one big controversy has been, if plaques are so significantly cleared, why is the clinical benefit so much smaller? So you saw 0.48 on the mini-mental status exam. So it's not really clear that this is really improving people's function. This brings to bear statistical versus clinical effects. It's hard to judge what 18-month small clinical improvements really translate and mean for quality of life. The risks, as I've outlined, are not trivial, and at present, they necessitate serial MRI monitoring. Of course, the cost of these treatments is high. Some insurances have moved to cover them, but that remains an open question as to equitable access to these treatments. In addition, for caregivers, they present a time burden. And because only 20% of people who were referred for clinical trials were even eligible, it's likely to be even smaller in the community when we consider that there are many patients with dementia who don't have Alzheimer's disease and may not be eligible for such treatments. Treatments have also not been tested in moderate or severe disease, and it was questioned as to why the FDA accelerated these treatments so quickly, and there were questions about the politics of that process. So I think we're in a stage where people are openly questioning the amyloid hypothesis, while again, these treatments may represent to some a confirmation of this hypothesis. Again, the clinical impact is small. And so we began to see more and more press around amyloid and whether this is really the underlying cause of Alzheimer's disease. One of the authors I like to think about, and I would encourage all of you to read this text, even though it was created before I was born, it's something that to me has been very influential in my career. And this is The Structure of Scientific Revolutions by Thomas Kuhn. And what Kuhn proposes is a cycle where we have a model that becomes the norm. It's now the norm, and if you question it, you're a heretic, and people look at you askance, and you're not really following everybody else. The model begins to show a bit of drift. Questions come up, controversies. This puts the model into crisis, at which point there's a revolution in re-looking at the model and eventually changing the paradigm. And I think a great example of this in our lifetimes is that of stomach ulcers. So when I went to medical school in the 1990s, early 1990s, it was taught that excess acid caused stomach ulcers, and that was the paradigm. And there were many medications coming out, and we treated people with acid blockers, and there was a lot of money to be made through looking at those treatments. Well, there was a gentleman in Australia called Barry Marshall, and he had biopsied a patient who had stomach ulcers and isolated a bacteria called H. pylori. And over the years, he tried to convince the field as kind of a lone voice that H. pylori was the cause of stomach ulcers. Eventually, he actually infected himself to show that this caused stomach ulcers. And of course, we know that eventually that paradigm shift won out, winning Dr. Marshall the Nobel Prize in 2005. But along the way, he incurred quite a bit of wrath as a heretic, and he held out, luckily. And now we find that antibiotics are a standard treatment for stomach ulcers. And so what we might think about is that the amyloid hypothesis may be a bit in drift or in crisis, and we're in the process of seeing some revolution. So one of the places that we've seen many other risk factors come up is from the Lancet panel that I have had the privilege of serving on since 2017. And the Lancet panel looks at expert proposed risk factors and analyzes them and looks at risk attributable fraction and estimates what effect those risk factors have on the development of dementia. And just want to highlight a few that really stand out to me as being something that we as psychiatrists who are involved in the medical care of patients should look for. One is thinking about education, and this is more of a altruistic goal, but the idea that education is protective against dementia, and having less education is a risk factor. So making sure that people go beyond basic education and get that additional education in high school. Hearing loss is another one. When we found this and saw the risk, we actually questioned it and redid the analysis, but now this has driven the field to discover that hearing loss is associated with dementia, and that mitigation of hearing difficulties is also associated with a decreased risk of dementia. I also want to highlight depression. This is another reason to treat depression vigorously, is we may be preventing dementia. And then in later life, thinking about social isolation and how social isolation can lead to dementia, very important to think about in the biopsychosocial model. Air pollution is one, especially in places where there may be developing economies where that is a large risk factor for dementia. And lastly, a new one we found on the last round of the Lancet panel was visual loss. So again, important to correct visual abnormalities. And if you add all these up across the lifespan, we believe that almost half of dementia is potentially modifiable. And we can think about this like the Framingham study, where when we began to study cardiac risk factors, it was prevention was a gleam in our eye, but now it's thought to have really reduced the amount of heart disease in our population. And importantly, one of the things we're seeing increasingly in studies over the last decade is a downward trend of dementia incidence in industrialized countries. And it's thought that societal changes are shaping the risk factors you see on this slide to reduce them. And if we target modifiable risk, we can actually potentially modify those cases of dementia. I also want to speak just for a moment about the recent US Pointer study that looked at dementia prevention and found that the factors here, known now as the brain health recipe, are associated with a decreased risk of dementia. So regular physical exercise, health monitoring, nutrition, and adherence to what might be known as a Mediterranean diet, and then cognitive exercise, challenging your brain several times a week. So again, the idea that we can engage in prevention. So I think what we're looking at is a change in our paradigm of the amyloid hypothesis to incorporate that may be one piece of it, or it could be a byproduct of some other process. But we need to look at factors like inflammation and microRNAs, the gut microbiome, cardiac risk factors, as well as potentially viruses. Those are all very active areas of investigation. And I think opening our mind past the amyloid hypothesis will be very, very useful for the field. Lastly, I want to touch on neuromodulation. So you've probably seen the explosion of neuromodulation in your own settings and applied to treatment refractory depression, OCD, PTSD, smoking cessation. But we're now starting to see studies that apply neuromodulation to cognitive impairment. And this study came out in the last year, which showed a slowing of cognitive decline in people with depression and mild cognitive impairment using transcranial direct current stimulation. But there are also multiple studies going on now with transcranial magnetic stimulation, deep brain stimulation, and transcranial ultrasound. And I think it will be very exciting to see what those studies find in terms of changing the trajectory of cognitive impairment. And because many of these modalities have such few side effects in patients, this is particularly exciting. So I'm going to summarize by saying that the amyloid hypothesis is now more than 25 years old. And while these new treatments do significantly reduce plaques, the cognitive benefit is modest and the duration of effect is unclear. There are also issues with the implementation of these drugs, the safety issues and management of adverse effects, and eligibility criteria that may preclude widespread use. We know that new treatment paradigms are much needed and we believe very promising in this area. Thank you for your attention.
My topic today is accelerated transcranial magnetic stimulation, which I will also refer to as TMS. My goals for the talk today are to describe the basics of TMS for treatment-resistant depression, point out challenges in typical TMS treatment protocols, review factors that impact efficacy and practicality of TMS treatments, and discuss how TMS can be used in CL settings. Why do we need a new approach? The likelihood of responding to antidepressants decreases with each unsuccessful medication trial. Failure to respond to 2 antidepressant medications is defined as treatment-resistant depression. And treatment-resistant depression is a very common problem affecting 2.8 million people and costing $44 billion in the US annually. You can see the statistics here that 37% chance of remission of MDD with the first med, decreasing to around 30 with the second. And there's a large drop off where the third and fourth medication have under 15% chances of remission. A little bit about the history of TMS. TMS is founded on the principle of Faraday's law, whereby magnetic forces can induce electrical current. In 1985, so a full 150 years after the background theory for TMS was discovered, Anthony Barker made the first TMS machine. Research ensued, and in 2 years later, TMS machines were used to treat different psychiatric and neurologic diseases experimentally. And just 7 years later, or 8 years later, TMS was shown to have some impact in depression. Research accumulated, and finally, in 2008, the FDA cleared the first TMS device and protocol for major depressive disorder. 10 years later, TMS was cleared for OCD, and a much shorter protocol called intermittent theta burst was cleared for major depressive disorder. In 2020, TMS got an FDA clearance for smoking cessation. In 2022, the first accelerated protocol was FDA cleared. That's our SAINT protocol that we'll talk about later. In 2024, TMS was cleared for treatment-resistant depression in people 15 and over. And in 2025, just last month, accelerated deep TMS was FDA cleared. So you can see there is an explosion of new clearances within the past 5 years, and we anticipate that will continue. What is TMS like? Well, I have a video made by my colleagues at UC Davis that I'd like to show you.
Treatment-resistant depression is generally defined as depression that hasn't gotten better with trying 2 antidepressant medications. We know that after a person has tried 2 medications and has not improved, their chances of responding to a 3rd or 4th medication are much lower. We're excited to offer transcranial magnetic stimulation, or TMS for short. This is a non-invasive treatment that uses gentle pulses of magnetic energy to stimulate nerve cells in the brain. It works very differently than standard psychiatric medications, and it can work even when medications haven't been effective. When a patient comes in for TMS, they sit in a chair that looks a lot like a dentist's office chair, and we place a magnetic coil over a specific area of their brain. That magnetic coil generates gentle pulses of magnetic energy that will stimulate the nerve cells in that region of the brain. So when these gentle magnetic pulses reach the surface of the brain, they cause the nerve cells in the brain to fire and send a signal. What that does will depend on what part of the brain you're stimulating. For example, when we place the magnetic coil over the motor area of the brain and we send one of those pulses, we can send a signal from that nerve cell all the way down a patient's spinal cord, down the nerves in their arm, and cause movement in their hand. For depression, we're treating a different area of the brain that's involved in
Thank you for watching that video demonstrating what TMS is like. So now I wanted to talk a little bit about the disadvantages of standard TMS. So people experience side effects. They're limited, but they are significant. Headache, regional pain at the treatment site, fatigue, tinnitus, and in rare cases, seizure. Even if insurance is covering TMS, it can be expensive with up to $100 per treatment session copay. There are exclusionary criteria. These include metal implants near the site and pregnancy. Finally, it is inconvenient. It's 5 days a week for 6 weeks. Treatments can take up to an hour, and it takes weeks to achieve remission. So the question is, what can we do to make TMS a more practical and easy to access treatment for our patients? Can we speed it up? Well, actually, we probably can't. So in 2018, the FDA cleared a new protocol, which is called intermittent theta burst. So this is a treatment that is 3 minutes versus the traditional 20-minute protocol. There's slightly more discomfort during treatment, and patients still have to come every day for 6 weeks. What if we put many treatments condensed into a single day? And that has turned out to be a very successful technique, really brought to the fore by a group at Stanford who developed a protocol called the Stanford Accelerated Intelligent Neuromodulation Therapy, or SAINT. So SAINT produces a rapid and robust remission. 1 week of 10 sessions a day can achieve 80% remission from treatment-resistant major depression. So this was really astounding and has changed the field quite a bit. It was FDA cleared in 2022, and everyone's in the TMS world said, what is in the secret sauce? How were they able to do this? Is it the treatment location? So we generally treat at the left dorsolateral prefrontal cortex. Was it the treatment parameters? How many pulses are they getting? Is there a special amount of time in between sessions that they're doing? Or are they selecting patients who are primed for response? So this is what we know so far from the SAINT group about what the ingredients are. They do a functional and structural MRI to determine the treatment target. They are still aiming for the dorsolateral prefrontal cortex, but are looking for a specific area that is most likely to result in response. They are doing intermittent theta bursts, but not the standard 600 pulses. They are doing 1800 pulses at a slightly lower percent of the motor threshold. Usually we treat at 120%. They are treating at 90%. They are giving patients 10 treatments a day for 5 days with 50 minutes in between treatments. So overall, they're giving more pulses cumulatively, more pulses per day, and accurate and precise location for treatment and an optimal intersession interval. Reviewing the demographics of their patient population, they're quite a diverse group with high levels of treatment resistance as seen in real world TMS groups. So there are some side effects to SAINT TMS, including headache, fatigue, facial pain. They had 1 dropout due to anxiety. As far as durability, it looks like at 4 weeks, there's 45% remission and remained at 63% response. At 12 weeks, there's some diminishment with 32% in remission and 37% response. There's now an open label study on continuation SAINT to see if some less often maintenance therapy will help preserve the response. There are some challenges with SAINT. One that many centers are coming across is how they get the MRIs done and paid for, as MRI for procedure is not generally accepted for payment by insurance companies. Overall, the payment model is a challenge, as insurance companies often do pay for standard TMS. Many private insurers have not started paying for accelerated TMS. Staffing a clinic that is open for more than 10 hours a day can be quite challenging. And finally, IT integration. We can speak personally at UC Davis. It is difficult to convince medical systems that it is safe to integrate software from an outside company with your own health information systems. Another new technology within TMS is deep TMS. If you look at the diagram, the top diagram on the left, the coils used in deep TMS cover much more of your skull and are able to penetrate more deeply into the cortex. This allows for overall a more successful and deeper treatment that does not require neuronavigation to make sure you're getting the right spot. Overall, deep TMS, even at a normally paced protocol, may be more effective than figure 8 coil for treatment-resistant depression. There's not as much data, but it appears to be that the remission and response rates are a bit higher than traditional TMS. Also, deep TMS has indications for smoking and OCD using slightly different treatment coils, but the same stimulator. And just recently in September, the FDA approved an accelerated protocol for deep TMS. So there are some disadvantages of deep TMS. You can see that the increased penetration also results in an increased seizure risk compared to the figure of 8 coil, and there's more discomfort during treatment and higher rates of headache. The basis for the accelerated deep TMS FDA clearance was a randomized controlled trial non-inferiority study where 5 sessions a day of deep intermittent theta bursts for 6 days. So they divided it into 3 days of 5 sessions a day over 2 weeks. And then they did a 4-week continuation period where there were just 2 sessions a day. And they compared it to the standard deep TMS, and they saw very high rates of remission and response in both arms of their treatment. And it's based on that they got the FDA clearance. So this was also observed to be very successful in a real world study where patients had between 3 to 5 treatments a day of deep TMS. So why should consult psychiatrists know about TMS? Well, it's safe and well tolerated in medically ill and older patients. As CL psychiatrists, we are comfortable with the interventional model. We do consultations, we offer treatments, and then we return patients to the referring provider. Many of the referrals for TMS are made by family practice providers and internal medicine providers who we already collaborate with. They feel very comfortable referring patients to us and having us give them recommendations when they are finished with the treatment. Finally, accelerated protocols are attractive in acute settings and will be increasingly incorporated into hospital-based treatments. So patients who are hospitalized for a medical illness who are also depressed may be eligible to have an accelerated treatment protocol that can be done while they're still undergoing their acute medical treatment. Here are my references. Thank you so much for listening to this talk.
Good morning. It's always a great privilege to attend and or otherwise present at the ACLP. My teammates and I are very pleased to do this triad of presentations for you this morning on advancements in neuropsychiatry more broadly. Thanks to Dr. Kahn for the generous introduction. Dr. Kales and Dr. Kahn and I are teammates at UC Davis as stated. My part of the talk is vagal nerve stimulation, or VNS, and deep brain stimulation, or DBS, for treatment-resistant depression, which represents what I call the intersectional triad among psychiatry, neurology, and neurosurgery. Again, as mentioned by Dr. Kahn, I'm at UC Davis, where I'm Vice Chair for Hospital Psychiatry Services. My disclosures, I'm going to linger on this a bit because the disclosures sort of explain the content in a reasonable way. First, I am funded by Abbott as the local primary psychiatrist for the Transcend protocol, which is spelled out there. It's a prospective, multi-center, double-blind, randomized, delayed stimulation, sham stimulation controlled 12-month study to evaluate bilateral stimulation of the subcallosal cingulate white matter using the DBS system as an adjunctive treatment for non-psychotic unipolar major depression in adults in a current major depressive episode with inadequate treat response. Dr. Brandman listed is the neurosurgeon. He's actually the local PI, and we started the project about a year ago. Again, this is I'll talk about this in a bit more detail in the content of DBS. This presentation includes descriptions of the study and images of the DBS procedure. In addition, and unrelated, I was funded for a two-day meeting on vagal nerve stimulation in December 2024 by LivaNova, who is the manufacturer of the VNS device. I did not receive research funding. We have been approached about interest in a VNS from a research perspective. We are also early stages of adopting VNS at UC Davis for treatment-resistant depression in collaboration with neurology and neurosurgery, though that's not a research protocol. Of course, we will describe the Recover VNS study and show the images of the VNS device. By definition, off-label interventions will be discussed since that's what these things mostly are. Here are my learning objectives pertinent to the application of advanced neuromodulation for management of treatment-resistant depression. I hope at the end of the presentation, attendees will be able to first describe the rationale and surgical approach to vagal nerve stimulation. Secondly, describe rationale and surgical approach to deep brain stimulation. Pardon me. Thirdly, detail the collaborative approach among psychiatry, neurology, and neurosurgery in the tri-management of these obviously very complicated patients. So just a few comments about treatment-resistant depressive disorder more broadly. Dr. Kahn mentioned this as well. I'm just going to reinforce this. Treatment-resistant depressive disorder is a major source of morbidity and mortality by suicide, self-neglect, and complications of catatonia worldwide. When studied, it's always among the top 10 or 20 most impairing illnesses in most populations. A conventional definition of treatment-resistant depression, obviously there are some differences, but what it means is failure of 2 or more full treatment trials of 2 different medications, again, at adequate doses, long enough duration, and at adequate compliance, and or evidence-based psychotherapy specific to depression, such as ACT, CBT. This is the usual minimal qualification for any neuromodulation, which we will lump under the category of interventional psychiatry. Caveats in this, implicit or stated, are this requires measurement-based care, otherwise you cannot really define the patient's condition well, and you need adequate doses, duration, compliance, and tolerability of medications to give things a fair try. Conventional neuromodulation, such as what Dr. Kahn discussed in her intro on TMS, includes rTMS, S-ketamine, or off-label ketamine. I'm not going to discuss those, but those are usually in the treatment-resistant depression paradigm. And of course, ECT, which is usually the farther along treatment. However, this begs the question, what do we do for interventional psychiatry treatment failures, i.e. multiple medication fails, failure of ketamine, failure of TMS, and failure of ECT? Well, these techniques offer hope for these patients and thus should be a great interest to us. So in the right box, the gold box, we call advanced neuromodulation. That includes vagal nerve stimulation and deep brain stimulation, which I'll describe in a bit, but others under development, which are very intriguing, transcranial direct stimulation, focal ultrasound stimulation. These are all offer promise for the future, but are not as yet in a clinical paradigm. So let me progress to vagus nerve stimulator, or VNS. This operates by stimulating the afferent left vagus nerve. Why the left vagus nerve? Remember, vagus nerve, of course, is bilateral, but the right vagus nerve is mostly efferent, going down into the soma, whereas the left is mostly afferent, going back up into the brain. Therefore, that's an appropriate target. The idea is that stimulation of the afferent nerve leads to the nucleus of the solitary tract, or nucleus tractus solitarius, if you prefer the Latin. At that point, this impacts the levels of monoamine neurotransmitters, serotonin, norepinephrine, dopamine, as we're familiar. This kind of in a sort of a neuropharmacological way explains why this is helpful, because it gets into the nucleus tractus solitarius and thus offers further modulation of the monoamine system. As a result of that, other pharmacology can continue while patients are getting vagal nerve stimulation. Now, these mechanisms are additive, not competitive. The FDA approved treatment-resistant depression and seizure disorder by vagal nerve stimulator treatment since 2007. However, it's not fully supported by the CMS for payment for depressive disorders alone, which leads to insurers not accepting VNS for simple depression. It is primarily implanted for seizure disorders, and particularly intriguing and hopeful for patients with seizure disorder and comorbid depression. This is what motivates the recent RECOVER trial, which I'll reference a little bit, which showed using VNS for treatment-resistant depression, there are positive effects on depressive symptoms, more for partial than full response, which continues to be elusive. But there was significant response on several rating scales in the final 10 or so months of treatment. In other words, patient would get implanted, the device would be turned on. The effects of VNS are not immediate, but rather cumulative. So after many, many months, they seem to have the effect then. Okay, so that's the context and a bit about the technique. So what are the considerations? Why would this be appealing for certain patients? Well, on the spectrum of neurosurgical interventions, an important caveat, the vagus nerve stimulator is a relatively low-risk procedure. Again, it does not involve surgery on the brain itself. It's only a dissection into the left vagus nerve, placement of the device, which I'll show you a picture of, and then an implantation of a battery. Now, there are sometimes some vocal side effects because the recurrent laryngeal nerve, which is anatomically nearby, can be affected. Patients who may report a bit of hoarseness or breathiness to the speech, rarely of great significance, but may be present. There's no requirement for an intracranial device since the device is peripheral. Analogous to a pacemaker, a cardiac pacemaker, it does need periodic interrogation and eventual battery replacement. As I mentioned earlier, the onset of full effects can be delayed for several months because the effect is sort of cumulative through the nucleus of the solitary tract. Now, this hasn't been proven or really established yet, but because of the peripheral location of the stimulation, it's plausible that a patient could eventually have supplemental TMS or ECT, since it's anatomically quite distinct from the areas affected by those interventions. Now, this is a image of what this looks like, the patient in the background, of course. And you see in the left vagus nerve, which is expanded in the circular right picture, the stimulator is placed there. And notice there are three leads coming off of the device into the vagus nerve. The electrode is then powered by a pulse generator, which is shown back in the upper chest. Again, rather analogous to a cardiac pacemaker. So once implanted and the patient is healed, tonic activity is presented from the pulse through the pulse generator, stimulating the vagus nerve as I described earlier. Again, this is rather unobtrusive. That does not involve intracranial surgery. It's externally relatively innocuous, doesn't have a particularly unusual appearance, and is generally pretty well tolerated by patients who need it. Okay. Now, the RECOVER study, relatively recently completed, was a 1-year randomized sham-controlled trial of VNS for treatment-resistant depression. The 3 papers are cited here. First by Conway. Very important to remember that this is a severely ill group of patients. The median patient in this study had had 11 lifetime failed antidepressant treatments. That's 3 or 4 times the usual threshold for treatment-resistant depression. 3/4 of these patients had at least one other neuromodulation. Most of those were ECT. Patients had severe disability, were typically unable to work or function in any meaningful way, and had severe suicidality, which is no particular surprise. So again, a very ill group of patients that even get this offered. Now, the Rush et al. Paper is the first paper describing the results of the study. Active versus sham showed some improvement in quality of life and enjoyment and satisfaction, and work productivity and activity questionnaire, as well as time spent in clinically meaningful benefit. I emphasize this is not remission, but this is benefit from baseline that is clinically meaningful to function and could be demonstrated. So given how ill these patients are, I would argue it's kind of unrealistic to expect complete remission in many of them, but as an intervention to supplement what had gone on before with sustained response, that's kind of where the promise seems to show. The Sankheim et al. Also commenting on the RECOVER study concluded in a more contextual sense that partial response rates with vagal nerve stimulator are much more likely than full response rates, which again, given the chronicity of illness and severity, is probably unrealistic. And importantly, that the active versus sham outcome differences were higher after 10 months of stimulation. So the stimulation for the first 2 or 3 months may not be as productive in symptom improvement, but the cumulative effects over several months seem to be more meaningful. So that's where we think the current state of the art is with VNS. Again, obviously, given its basic indication, VNS for seizure disorder complicated by depression would be sort of added into this mix. Okay. Conversely, deep brain stimulator is an entirely different technique. This is an implanted inhibitory neurostimulator into the subcallosal cingulate. It's already commonly used and, in fact, rather routine treatment for moderate to severe Parkinson's disease, where the implantation is in the subthalamic nucleus. In TRD, it's the same device connected to the subcallosal cingulate. The model there is that in depression, that particular tissue is paradoxically overly active, which correlates with the depressive condition. Therefore, the deep brain stimulator, when implanted in the SCC, inhibits the activity of that tissue. This is described in a paper by Drevitz, which I've cited there. Deep brain stimulator is already approved and, in fact, commonly used for severe Parkinson's disease, epilepsy, and essential tremor if it's functionally impairing enough. The study we're involved with, the Transcend study, is specifically for treatment-resistant depression. The broader design of this study is a 3-year-long study where all patients who meet the rather rigorous qualification criteria, such as no history of bipolar disorder, no history of psychotic illness, other qualifications. All patients get implanted, and then there's a randomization process then. So one group gets a 1 year of sham, whereas the half of the group gets active stimulation. After year 1, the sham group is then stimulated, as was the stimulated group. So years 2 and 3, basically all patients get the same intervention. Obviously, the outcomes of the study are going to be based upon the various details of the 1 year experience. While the patient is getting the stimulation from the DBS, they can continue all other psychiatric interventions with some restrictions. They continue psychotherapy, they can continue medication treatments for other aspects of the disease, such as anxiolytics and sedation. But medication changes to the antidepressant pharmacology specifically is discouraged so as to isolate the variables to the degree possible. The patients are seen very frequently throughout this year. Regular psychometric measures are taken on various study parameters, and that is then retrospectively reviewed. So in contradistinction to the VNS, where do we see the DBS fitting in? Of course, compared to VNS, it's much more highly invasive. But I emphasize it's a highly invasive procedure that's already used for other illnesses. So it isn't as if it's a fundamentally different construct. The patient cannot have another DBS at the same time. The DBS is compatible with all the medications we use. Yet unknown, and this is something that's going to have to be determined, the presence of the DBS device may well limit later ECT or TMS. Like the VNS device, it needs periodic interrogation and battery replacement. They're estimating maybe every 2 to 5 years a battery needs to be replaced. At the current state of the art, and again, the state of the art is evolving in a very interesting and exciting way, we would probably regard this as the highest level somatic intervention for major depression, pending the development of other techniques. Now, here's some review citations on DBS. The study on the left, the READY study, reviewed 15 trials of DBS for treatment-resistant depression, with some improvement in long-term depression scores, both short-term and the longer term, and the response rates are cited there. But those studies are somewhat underpowered, arguably, which is why the big new study is being done with a total of 100 subjects. The Dong study on the right, in past applications of DBS, various surgical targets have been tried. The subcallosal cingulate, as in our study, nucleus accumbens, ventral capsule, ventral striatum, and anterior limb of internal capsule. It's all very interesting literature with which you might want to acquaint yourselves. Now, this image here shows the left schematic of the bilateral DBS stimulators in place. You see the little blue circles at the treatment target. The stimulator leads then run past in a parallel way to a DBS battery device and stimulator placed in the upper chest, similar to the VNS procedure, except of course it's bilateral. The right side is a reminder of your neuroanatomy. The orange tissue is the subcallosal cingulate. If you look at the anterior under the corpus callosum, down here, this is where the device is actually implanted. Okay. So putting all this together, and with the understanding that this is an evolving area, nonetheless, I would argue these two interventions and those other ones to come offer great promise for a group of patients who with other maximized treatments often do not do very well. I think all of us should appreciate that the brain is a complex organ. Therefore, as a complex organ, it deserves the attention of 3 medical specialties. So psychiatry on the left, what is our role both currently and anticipated in all of this? Well, of course, we're going to continue to do the currently conventional neuromodulation procedures such as TMS. Of course, we're involved in case finding, case stratification, and classification of major depression cases for patients who might be candidates for these other interventions. Of course, we provide the post-op ongoing monitoring and further interventions within whatever limitations might be specified by the invasive procedure. Specifically to CNL, well, we need to be aware of these because of the significant overlap between CNL and neuropsychiatry. I would argue CNL is substantially neuropsychiatry in the first place. Thus, when patients are admitted to hospital or in other high-intensity environments, we need to be consultant on those, and we need to be aware of the implications of these devices. Not presently practiced, but I think relatively soon we will probably be actively involved in interrogation and adjustment of the device to change the stimulation to treat depression. Neurologists, very important because specific to the VNS, this is already being done for patients with either seizures alone or seizures with depression. Thus, there's neurology comorbidity to manage along with a psychiatric comorbidity. So inherently, we and the neurologists collaborate on the neuropsychiatry of comorbid patients. Parkinson's disease, Huntington's disease, numerous examples of that. Neurologists are already involved in interrogation and adjustment of the device when the VNS is used for treatment-resistant depression. And our neurosurgery colleagues on the right, of course, they are responsible for device placement, managing the perioperative aspects, and also involved in device interrogation and adjustment, and ultimately, depending on the patient's long-term function, battery replacement, which fortunately, from a neurosurgical point of view, is not particularly challenging and is usually a fairly routine procedure. With that in mind, I want to thank you all for your attention. In summary, I think DBS and vagal nerve stimulator and other yet to be developed and offered neuromodulations for depression offer a substantial opportunity for advancement of the field, for psychiatric practice within the expanded options for the field. There'll be a lot more to come on this. I would hope we can yearly present on this again and talk about things as they develop and are implemented into routine practice. Thank you so much for your attention, and I hope you all enjoy the rest of the meeting.